Happy Wednesday. I am Alexis Davis. I'm the social media manager here at RSDSA. I'm joined by Jim Broach, Executive Vice President and Director of RSDSA, and Dr. Wayne Jonas. Dr. Jonas is very accomplished, so I'm going to read just a bit from his bio this evening, and then we're going to go ahead and get the conversation started. Dr. Jonas is a practicing family physician, an expert in integrative health and healthcare delivery, and a widely published scientific investigator. He is the Executive Director of Integrative Health Programs for the Samueli Foundation. Additionally, Dr. Jonas is a retired Lieutenant Colonel in the Medical Corps of the United States Army. From 2001 to 2016, he was President and Chief Executive Officer of the Samueli Institute, a nonprofit medical research organization supporting the scientific investigation of healing in the areas of stress, pain, and resilience. His work at the Samueli Institute set the bar for evidence-based research in the areas of pain, stress, and human performance. He has led and participated in hundreds of research studies, beginning with his time as director of the National Institute of Health's Office of Alternative Medicine. His research has appeared in peer-reviewed journals, such as the Journal of the American Medical Association, Nature Medicine, and the Journal of Family Practice. Please remember that while the information shared here is helpful, please also make sure that you are consulting your physician for personalized medical advice. Jim, do you have any announcements before we turn things over to Dr. Jonas?
Just two quick announcements, and welcome, Dr. Jonas. We're real excited about your talk tonight. I just wanted to encourage everyone who's not a member to join us. We just published the June issue of In Rare Form. It had a great article on ketamine and low-dose naltrexone. Alexis will give you a link to join if you're not a member. It's free. It's sent electronically. And also, we're redesigning our website, and we want to offer the community an opportunity to view our website and make some suggestions so we can better serve our community. And that's it, Alexis.
All righty, and then I have one quick announcement. So, of course, we have this amazing Facebook Live happening right now, but our next Facebook Live will be next Thursday, June 17th at 7 p.m. Eastern. We'll be joined by faculty experts via Abbott to discuss living with chronic pain and DRG therapy. More details on that will, of course, be shared soon. But right now, it's all about Dr. Jonas, so we will turn it over to him. Thank you for joining us.
Thank you very much, Alexis, and thank you, Jim, for the announcements and for inviting me to come and speak to your group on this Facebook Live. It's a great pleasure to be here. Can you all hear me? If you can't, let me know, Alexis. You hear me okay? Okay, great.
Yes,
thank
we can hear you.
I'm going to go ahead and share my screen and make a few comments for about 30 minutes, 40 minutes, and then open it up to some questions. Is that okay? And let me just check there. Are you able to hear my screen, see my screen with that?
Yep, all is well.
Okay, very good. So I want to talk about non-pharmacological and behavioral approaches to chronic pain. This is an area that we are often hear about, and we're often told should be an important part of chronic pain management. And yet, if you walk into your average doctor's office, your average healthcare system, it may or may not be addressed, and frequently is not. So I want to talk to you about why it's important. Really, healing it is important to know what the processes of healing occur and how to make it happen both in your life with your provider and with your healthcare system. So I won't belabor this. This is my background, and Alexis did a good job of sort of summarizing that. Thank you very much. I currently see patients in a primary care clinic, and the focus of that clinic is chronic pain. I hope that at the end of this talk, you'll have learned a few things. One, that you'll understand where healing comes from. Very, very important if you want to try to get it, right? And what our healthcare system needs to deliver it. And so you can look for it. Identify at least 3 dimensions of integrative health, and I'll define what that is for you, in chronic pain and what scientific evidence there is for those dimensions. Learn about some tools that are available to make this easier for your average physician and healthcare system and a patient to deliver. I call them the Hope Note tools, and we'll show you what they are, specifically on how they apply to pain, and then learn how healthcare systems are now beginning to tap into these things. More important than these more technical objectives is that I hope on Monday, you'll begin to see people as whole people. If you're a provider, you won't just see them as patients, you'll begin to see them as persons. And you'll know how to remain a healer, whether you're a person who is a provider or not. You're all healers, and how to tap into that inherent healing capacity. You'll know how to access these Hope Note toolkits, which is free on my website. And then you'll know what's needed in order to transform our healthcare system to one that is whole person and integrative. The fundamental question that we should all be asking if we're faced with chronic pain or any chronic condition is, how can we integrate healing and curing? And I'll show you why this is a key question, because curing really has to do with the patient. And even in so-called patient-centered care, you're already categorized as somebody who's not necessarily a person, you're a patient. And that means that you're asked, what's the matter and what can I do for you? And yet, without connecting that to you as a person, asking what matters to you, you can't actually incorporate, as I'll show you, the fundamental dimensions of healing and the underlying determinants. There's so much talk nowadays about healthcare and healthcare reform, and this is also going on even now. And the question is often about, well, how do we get universal healthcare coverage for medical care for everybody? But I would like to suggest to you that that is the wrong question. That the question really in healthcare reform should be, how do we get from healthcare to actually the creation of health and well-being? Because if healthcare is not doing that, then why is it here? Why do we need to ask this question? Well, staying in the healthcare only box, the medical care only box, is beginning to lose value. And it's actually not worth the cost anymore. And most people acknowledge that. We are first in this country in spending. We're 37th in healthcare metrics, according to WHO and others. 20% of our gross national product is going to be spent on healthcare by 2025, a huge amount. And with the increasing costs of healthcare delivery, there's a widening gap between those who can get it and those that can't get it. Healthcare disparities are increasing, the opposite direction in which we would like to go. There's lots of data to support this, and I'll point to one, which was a study over almost 30 years of all the rich countries in the world, the OECD countries, by the Institute of Medicine, now called the National Academy of Medicine. And what they looked at was, how were we doing in healthcare compared to other countries like ours? And we found that, in fact, our lives were getting shorter, and for the vast majority of conditions such as this, things were getting worse. In fact, if you graphed the cost of healthcare in the US against life expectancy, you could clearly see the losing value in what we're doing, because the US was spending over double of any other country in healthcare, and yet its life expectancy was somewhere around Czechoslovakia or Portugal, who spent significantly less. We were not getting the value for our healthcare dollars. We also know why this is the case. And that is because medical treatment, even with full coverage, and I'll show you a case that had that, and the example of that only produces about 15 to 20% of actual health. And that's in the individual or in the population. And that's because health comes from places outside of medical treatment. The two biggest areas are the behavior and lifestyle area and the social and the economic impacts in those areas. So if our healthcare system wants to be part of the solution to creating health, it needs to get out of that top box and begin to facilitate the other determinants of health that you see on the right and the left here. Well, we can't do that by using the medical tools that we currently have, because the medical tools were built for the box, only the 15 to 20%. Here's an example of one of those tools. Those of you that are care providers know this tool. You learned it. You apply it every day. It's called the SOAP note. And if you're a patient and don't know this, you should know this. Every time you walk into a doctor's office, you are put into a SOAP box, and that is they're trying to find the subjective, what you described, the objective, what they can observe and test, give you a diagnosis that matches a code that they can bill for, and then a plan that then will address that diagnosis. The question that they're trying to answer is, what's the matter? What is the medical diagnosis and what is the treatment plan? And this is the primary tool around which not only is the visit structured, but our whole health electronic medical record is structured in those areas. This is the tool. Let me give you an example of a patient that you actually might recognize. Perhaps some of you listening to this have a similar issue, perhaps not with back pain, but with complex regional pain, but a chronic pain syndrome. Sally, I'll call her, was an executive vice president at a large company, and she had top-level health care, full coverage, all specialists, all medications, all primary care visits were covered. She had a car accident, and then she developed chronic low back pain. She had a lot of soaps applied to her over the over 10 years that she had before she came to see me, all asking, as the SOAP note does, what's the matter? And over that period of time, this is the kind of thing that she got. And again, you may recognize a lot of this. Many x-rays, CTs, MRI scans to determine what's the matter. She was found not to have a major lesion in her back, but she had chronic pain. She was put on non-steroidals and physical therapy at first, then TENS and other electrical stimulation. She got injections with steroids. She had surgery, not once, but twice. She didn't have an implanter, but she could have. Then she was put on opioids, and then she was taken off opioids, and she was put back on opioids, which she liked because it gave her the most relief that she could find. Eventually, she was sent to behavioral medicine, where she got another diagnosis, depression, and put on another medication, and told to go to opioid recovery. When she first saw me, the first thing she said is that I'm not crazy, and I'm not addicted, I'm in pain. Many of you can relate to that. Here was Sally's team over the 10 years that she had this chronic condition. She had the primary care doc that she saw to first diagnose it. She was sent to physical therapists, to pain specialists who did mostly interventions of some type. She had the surgeon who did the surgery. She was sent to behavioral medicine, who wanted to do counseling and suggested the antidepressant, and the pharmacologist to help her juggle all the medications that she was on. I put the word team in quotes because it was not a team. These folks were not working in a coordinated fashion to help give Sally a common vision. And her coordination of this was one of the biggest problems of integrating her care because it is so disjointed, even when you have good health care. Now, Sally is not alone. Many of you know this data. This is pre-COVID data. Opioid prescriptions have increased significantly in the last decade, and opioid-related deaths have gone up. From that, over 12 million Americans pre-COVID were misusing opioids. Every state in the union, 2 presidential commissions have all talked about the need to address the opioid epidemic. How much have we heard about that during the pandemic? Well, I'll tell you, it has gotten worse during the pandemic. And so these numbers are actually higher now. It's not gone away. Even before the pandemic, most of the guidelines that came out from prominent groups like the American College of Physicians, the VA, the FDA, the Joint Commission, all said that we should not use as many drugs, especially opioids, and we should go more and more to non-pharmacological, drugless approaches to chronic pain that had good evidence. And they listed the evidence and the areas that should be used prominently. And so these are the guidelines that your physician and healthcare system has been getting. Had we been listening to patients for the last 30 years, we would have realized that they were already doing this. They just used a different term. It was called complementary and alternative, or complementary and integrative medicine. And it consisted of things like therapeutic massage, yoga, acupuncture, spinal manipulation, mind-body practices, very few of which were integrated with their medical treatment, and very few of which were actually covered and paid for by the healthcare system. And so now we had a situation in which the advisors, the guidelines, were telling us the systems to do it. The patients were already trying to do it, and caught in between were the people actually delivering it, who had never been trained in these things and didn't know how to integrate them into chronic pain management. What was needed was not new guidelines and not new evidence, although new evidence is always helpful in these areas, but really a change in our thinking. What we needed is we needed to treat chronic pain like other chronic conditions as an ecological, as a whole person, in a holistic way, and rather than a mechanical way. We have a wonderful acute care system in which if you have a heart attack, if you're in an accident, you need surgery, you can have your life saved. If you need something removed, the surgical components can be life-saving. But this treats parts of people. And after that, for the chronic care, we need an ecological mindset, which looks at whole people and communities. This is a different way of thinking. Well, to apply that, we need to have different tools. We can't use the tools like the SOAP note to do that. And so I and my colleagues have developed a different set of tools that they're here to facilitate the healthcare system and your provider and you to actually apply a whole person perspective. We call it the HOPE note. This stands for healing-oriented practices and environments, and it involves 4 different dimensions of a human being: the body and the physical, the behavioral and the lifestyle, the social and emotional components of a person, and the spiritual and the mental components. It starts with that central aspect by exploring not what's the matter, but what matters to you as a person in your life, and then looking at your underlying determinants of healing and supporting making those available and delivering those in a coordinated fashion. This HOPE Note toolkit consists of a series of things, something called the personal health inventory to help change the mindset, and the dialogue that goes into practice to connect with the patient, to engage, educate, and learn. That's the HOPE Note itself in the center here. And then discovering solutions, especially non-drug solutions, into a personalized health plan. Among that comes a number of supporting resources to help get information, access, implementation of these tools. Here's an example of the personal health inventory, and you can download this off my website. It's an easy 2-page inventory that I've adapted from the Veterans Administration, and it asks, first of all, what is the dimension of a whole person? I've just shown that to you. And it asks you, how's your health and well-being? Not just how your pain is and how your condition is, but how's your physical, how's your mental, and how's your life overall? The second page then first asks, what do you live for? What matters to you? What brings you joy? In other words, why do you want to have health? Simply getting health care doesn't make any difference, or getting health doesn't make any difference if you don't know what you're going to use it for. So it starts with these questions. And then it begins to look at the underlying determinants of health are outside of that medical box that provide 80% of healing, and narrows down on where you're ready to improve and work. Here's some of the questions that go into the actual dialogue of a HOPE Note encounter. It includes questions about your body and your external environment. It includes questions about your behavior and lifestyle, and many of you will recognize that things about diet, sleep, stress, and activity all have an impact on chronic disease, including chronic pain. The social and emotional parts of your life, which are impacted by chronic pain and in turn impact chronic pain, including things that happened in your childhood, and the spiritual and the mental, which is the first question, what brings you joy? What's most important to you in your life? These are the questions that go into an actual encounter. Imagine a healthcare provider asking you these questions. Well, if they're using an integrative HOPE Note approach, they should be. Let me give you an example of how this happened with Sally when she came to see me. As you remember, her first comments were, "I'm not crazy and I'm not addicted, I'm in pain." So I asked Sally what mattered for her. And as often is the case, patients will tell me, "Well, I need help with all these medications. I got all these different drugs and interventions to manage my pain, and I just need some coordination of them. Do I need to be on all these? Do I need to do all these medications?" Fortunately, we had a pharmacologist that could help with that. But I said, "Sally, what I really want to know is that what matters for you? What do you do that's not simply a medical component to help you treat your chronic pain?" She actually knew immediately. She said, "In the morning, I get up and I notice that heat and stretching help. And so I get my cup of coffee and I get into the hot tub with the paper and I sit in the hot tub for about an hour or more and I stretch and stretch and stretch. And if I do that, then I'll be okay until about noon when I have to start taking my medication." So I began to ask her these questions that I showed you before. "How's your sleep, Sally?" "Well, oh, it's okay. I wake up." "Well, how much do you get?" "About 5 hours. I've always gotten about 5 hours. I've been a go person since the beginning of my executive job, and I still am that way." Sally was chronically sleep deprived and didn't realize that this was perpetuating her chronic pain. "How is your stress, Sally?" I asked her. And she says, "I'm not under stress." She said, "I was when I was working in a high-powered executive job, but I'm not anymore. I just sit around, take care of the house when I can, wait for the kids to come home and my husband to come home. And it's very unstressful." Well, I said, "What do you do to relax in the evening?" And she said, "I have a drink and I watch TV." Sally was totally unaware that chronic pain in itself is a stressor, that it exacerbates cortisol levels, it increases inflammation in the body, and it creates a negative feedback cycle that perpetuates chronic pain. What Sally needed was stress management techniques that could improve her parasympathetic nervous system function and block that cycle or interfere with that cycle or retrain her brain to respond differently to the chronic pain she was experiencing. When I asked her, I said, "Sally, have you ever done yoga?" Because heat and stretching sounded like that. She says, "Oh yeah, I did yoga. I went to a yoga studio and the woman up in front was all tied up in a pretzel. I tried it and I hurt myself. It doesn't work for me." Sally had not been given guidance, nor did she get in touch with somebody properly trained in therapeutic yoga for pain. And her physicians and her healthcare system didn't have that and didn't know how to guide her on that. And she thought it didn't work. And yet she was trying to do something very much like yoga for herself in the morning. When I asked her if she's interested in getting good therapeutic yoga, she was absolutely interested. But where would she do it, I asked. And she, in fact, had no idea when and where she would do it. And we had to work on that. When I asked her, could she do it in her bedroom? She said, "No, it's a mess all the time. The kids are coming in and out. There's no peace there." We actually had to find a time and a place to heal. But the most important thing in Sally's life was the central question, what's your meaning and purpose? She said, "I was great and my kids, when I was working, and my kids used to call me, didn't call me Sally." I said, "Well, what did they call you?" And they called me Salary because I was the breadwinner and I loved it. But since then, I'm no longer doing that. Sally had lost her purpose. She no longer felt like she was contributing back to her life in those areas. So we needed, in fact, to address this in some way. Well, with that story, we now knew what kind of team we needed. We had some of these in our healthcare system, the physician who acted really like the quarterback rather than the specific treater, the pharmacologist to help her with the medications, the behaviorist, but the behaviorist needed to be needed to act differently. The behaviorist needed to support Sally almost like a health coach. If she was going to engage in therapeutic yoga on a daily basis, and if her family was going to support her in those areas. We had those top three in red. We did not have the ones below, so we had to get them lined up. We had to find access to someone who knew how to do good therapeutic yoga. We needed her family support in making this happen. And mostly we needed her body to experience what it was like to get better, to feel better, to have reduced pain based on her own behavior and engagement. So once we lined this all up, we sent her to the yoga therapist. She had one session with the yoga therapist and she called me up. She said, my pain levels are down to 2. They haven't been down to 2 in probably about 5 years. Now, she was not cured. She needed all the other parts of the team to support her in that, to keep the engagement going. But after about 6 months, she was regularly doing yoga, therapeutic yoga. Her pain levels were down to 2. And after a few more months, she began to look for a job, regaining a core central meaning and purpose in her life. This kind of healthcare is a different type of healthcare. It's the kind of healthcare that looks at the whole person and then integrates or merges the conventional healthcare, the pills and procedures, the evidence-based non-drug approaches like complementary and alternative medicine, and behavior and self-care. It's that sweet spot in the middle of this graph. And of course, all that has to be done within the cultural context, the social and the economic resources available to the individual. But this is different. If we stay just in that top circle, we're going to continue to get the declining health outcomes, the increasing costs, and the widening healthcare disparities that we have. Now, along came a little bug, and I think most of you have probably heard about it. It was called COVID. It produced a global pandemic, and it certainly turned our healthcare system and our lives, all of us, on its head. Here's some of the impacts it had on primary care physicians. 25% of them lost members, 41% have unfulfilled staff, and a good half of them say we have increased mental exhaustion. Family decision makers, those who actually engage in deciding what healthcare to get, have reported more healthcare crises, more obesity and addiction, more community violence, and increased levels of pain. And increased racial disparities, as we've seen, have also gotten worse, and I'll show you some data on that. Healthcare executives have found that their ICUs have lowered capacity, their elective surgeries have gone down, their revenues have declined. Rural systems have especially suffered from this, and quality improvements, such as improved pain programs, have been put on hold during this time. Who dies with COVID? Well, unfortunately, it's the same people who died before COVID. It was those that were at high risk with chronic illnesses, such as hypertension, diabetes, obesity. The elderly, those with chronic disease, people of color, low income, poor health care, and those in service jobs were disproportionately affected by COVID. The life expectancy impact I showed you previously has gotten unbelievably worse. In a single year, COVID has dropped our life expectancy, which was already low compared to how much we were spending, by an entire year, and 3 to 4 times that in people of color. And once it's over, it's not over. We're all looking forward to it being over, but many, many people have persistent symptoms. Up to 1/3 to 1/2, possibly over 1 million to 2 million people may suffer from what's called long COVID or chronic COVID symptoms in these areas. These symptoms and dysfunctions affect every single organ in the body. There hasn't been an organ yet that has been found to be immune. And there's an increased risk of death, 60% higher if you've had COVID, regardless of whether it's mild or severe, even if you haven't been hospitalized. And long COVID, by the way, is independent of how severe your symptoms were. The slide I just showed you is just as prevalent in those with mild COVID disease than in those with severe COVID disease. So before COVID, we needed a whole person change in perspective, and after COVID, we need a whole person change in COVID. We need to look at all dimensions of a human being, body, behavioral, social and emotional components, and the spiritual and the mental in these areas. So holistic approaches are required that empower and support patients in their own self-care, that integrate conventional complementary therapies. And the evidence shows when this happens, people are healthier, they have less chronic illness, they get better faster, and they cost the system less. Can we do this within our current system? Well, I think the answer is, how can we not do it? Because if we don't do it, we're going to continue to see the challenges that I just showed you. Yes, there are systems doing this. Let's take a look at one, and this is the Veterans Health Administration. Over 6.5 million veterans, 9 million if you count those that don't get care in the VA, and they are transforming into a whole health approach, using personal health inventory and personal health plan that empowers the patient, equips them, and supports them in the treatment of their disease. They've shown that this model, even after a year of the application of this new model, has reduced costs and improved health. The cost reduction is almost $5,000 per patient in a single year, improved well-being and the experience. Non-VA groups have also adopted this. Here's Alan Roth. He's chair of the Department of Family Medicine at Jamaica Hospital Medical Center in Queens. This area is the most diverse city in America. It cares for the Jamaica Hospital cares for over 1 million people, 75% of which either on a Medicaid or have no insurance, so very underserved population. Before the pandemic, Dr. Roth was integrating health practices like I've shown you into the standard care for the safety net hospital. Then in 2020, they were in the center of the storm at the first COVID surge. They had 100 deaths a day. They converted a pediatric hospital into an ICU, and they have now launched the first long COVID or post-COVID clinic. We work closely with Dr. Roth to infuse whole person and integrative care into their system, and developing tools, especially pre and post-COVID, that they needed. And this included tools, and these are links here that you can all access. I'll send you these slides afterward. In fact, I think I've already sent them to Alexis, to avoid burnout, to enhance the immune system, and to build resilience. Let me show you some examples of that. Dr. Roth was using the Hope Note tools already, but what he did is he turned them on the providers first, because he found they needed integrative health and self-care, self-management, improvement performance as much as patients. He then applied them to the patients, specifically for COVID and COVID-related, and the community to address prevention care, loneliness, and trauma. Clinical burnout was a problem before COVID, and now it's even worse problem. American Academy of Family Medicine and the National Academy of Medicine were all talking about ways to reduce burnout and changing how practice is delivered along the lines of whole person care is one of those. Another one is the importance of mindset. I've worked for many decades in the military, dealing with people that have come back from deployment and war, with PTSD, with moral injury. And what we found over and over again is that those who go into a trauma and a stress with a positive mindset, expecting it to boost their resilience, will find that on the other side, they will have their resilience boosted, compared to those who have a negative mindset and expect to be damaged by it. So those who thrive have strong relationships and a mindset that changes this. So how do you change your mindset? Well, you change it with these kinds of resources. And these are, again, all available on my website. How to balance mind and body during the crisis. Imagery is a great approach in these areas. And we have free streaming images from a psychologist named Belaruth Naprasak, who's done extensive work in this area, and we've tested these tools and breathing components. Let me just show you two of those that you can start using very easily in your life and in your practice if you're a provider on Monday. Actually, you can use it right after this talk if you want. One is do a mind-body practice. Meditation or sympathetic exercise of the parasympathetic relaxation response has been shown to boost resilience, improve the immune system, and even grow the brain that reduces pain, and in fact, reduce pain. About 8 weeks of 20 minutes a day has been shown to do this. If you link this picture on the right-hand side I have a 17-minute mind-body gratitude exercise that many have found very profound. The other thing is something called a gratitude journal. Very easy to do. All it involves is at the end of the day, writing down 5 things that you're grateful for. And this has been shown in good studies to actually improve well-being and reduce burnout. And there's a link on my website on how to do journaling and how to do a gratitude journal. The social and emotional area has had a major impact during the pandemic, as we were told to socially isolate. We didn't want to socially isolate, we wanted to physically isolate, but the result was we also got socially isolated. And this has exacerbated something that we already had as an epidemic prior to this, and that was loneliness. Loneliness increases inflammation, it increases pain, it can reduce the immune system, and it increases the risk for mental and physical health problems and suicide. It's important to mitigate loneliness with what I call the healing presence. This means listening and connecting to others. If you're a provider, helping patients learn about resources and the changes that they can make to reduce loneliness. We have a whole guide on this, healing patients in the time of loneliness, sitting and being with patients to reduce the epidemic of loneliness. My mother, who is 94 years and was isolated during the pandemic, she stopped eating and was definitely going downhill. We had to move her to a place where she could have more social support. And when she did that, she began to flourish. She gained weight, she improved. And then, unfortunately, when she got COVID, she was able to be resilient and build it off. And fortunately, she recovered very well and is doing fine even at that age. Well, how does this all come together? What does this mean for how the healthcare system and you engaging in that healthcare system can begin to transform healthcare into this more whole person integrative component? Well, if you're a provider, here's some things that you can do. Of course, maintain good quality evidence-based standard of care. But then add a few things. Add an integrative health visit using the personal health inventory and the Hope Note. And I'll show you where you can get those, and you can begin to use these immediately. Add some simple non-drug methods like ear acupuncture, mind-body practices, nutrition, and safe supplements. And we have guides on my website in all of these areas. There's many technologies that can actually facilitate healing. Heart rate variability biofeedback, CES devices, behavioral apps, and telehealth are all growing in sophistication and utilization and can help in chronic pain. Most importantly, redesign your healthcare team. Incorporate health coaching that can help the patient make these changes in their life. Use team care, which reduces loneliness and improves motivation, group visits, and shared decision-making. All things recommended in our current healthcare system, but so often not delivered. Here is the steps to doing a Hope Note. It shows you how to prepare it, how to actually execute it, and how to incorporate resources for ongoing support. And again, all these are free on my website. There is a growing list of clinical implementation tools that we've developed and also collected from around the country, around the world, which show you actually how to support this kind of a process. And there is a growing network of clinical implication sites around the country that are implementing integrative health through the Hope Note in these areas, including those that are taking it off the website, doing it themselves, and joining learning collaboratives. In chronic pain, if you are a provider or you would like your provider to begin to use these tools for chronic pain management, we have the great fortune to have worked with Tufts University, who has created an entire certification program and training program in which the credits for training are free. And it is approved by the American Academy of Family Physicians, and they can learn how to implement these integrative approaches specifically for chronic pain. It's in integrativepain.cme.com, and I would urge those of you who are providers and those of you who are patients, urge your providers to take this course, and they can learn these tools for pain immediately. If you're a patient, there's a number of things you can also do that parallel this. One, focus on self-care. This is your job. So often, those in chronic pain are still trying to help others. Helping others is important, but as they say in the airlines, put on your oxygen mask first before you help your child. Heal the healer is very important. This is self-care. Ask yourself what matters. Take the personal health care inventory for yourself. You can find it online. Ask your provider to do an integrative health visit using the HOPE tools, and develop your own healthcare team and plan, integrating the best evidence from all different approaches. There are a number of resources around. Here's some, again, from my website, specifically for pain. A guide to clinical nutrition for chronic pain, especially what you can eat. I know that's a very important area. I think you have a speaker coming up on that. And an optimized approach for people living with chronic pain, and then a specific guide for women in pain. And in fact, women suffer chronic pain at a higher level, and they also get less support, less resources, and less interventions, so that this needs special attention. Here's an individual that many of you may know, Cynthia Toussaint. She has created an organization, that's her website, forgrace.org, specifically for women with CRPS and reflex sympathetic dystrophy, which she has and has worked with in an integrative fashion all of her life. I'd urge you to go there and look at the resources that she has specifically for the type of chronic pain that many of the folks in your organization have. What to look for in a provider? Well, some of the very same things that I've looked for. Ask your healthcare system, ask your providers, and choose those that provide these kinds of approaches that address the social and emotional domains, that have incorporated proven non-drug and self-care methods into their practices, that are open to the advanced healing technologies, and have redesigned their team for both an integrated and an integrative practice that is person-centered and focused on chronic pain. This is something you can start now, and I hope that you found this talk and these resources useful for you, and it's something that your healthcare system can begin to do too. So as advocates for yourself, as advocates for healing transformation, go get the resources, use them, bring them to your providers, bring them to your healthcare system, and change the way healthcare is delivered now. I want to take a few questions, and here's a few that were sent to me ahead of time, but we'll open it up, and Alexa, I guess, will open it up. And I'm happy to answer these that were emailed in first. I've actually provided some, but then if we have time, I'll open it up for some additional questions. Here's a couple that were sent in. I'll just go over these. Forteo, this is a treatment for bone loss. Is it worsening CRPS? I have not seen this in chronic pain people or in the CRPS patients that I've had. Neither is it listed as a side effect. But let me answer a question that came in related to environmental sensitivity below. This doesn't mean it can't happen. Somebody asked how you get low-dose naltrexone prescribed. Low-dose naltrexone. Naltrexone is an FDA-approved drug as is, and you can ask your physician to prescribe it off-label in a low-dose fashion if it's something that they and you want to do. I've been asked about household airborne chemical exposure, such as fresheners and cleaning products, and whether that contributes to CRPS and other health issues. I have not seen this, but there are patients that do have environmental sensitivity, that do react to even small doses of some of these household chemicals. Some of these patients do have chronic pain and CRPS. And so if you're in that category, then that kind of exposure can exacerbate things. And you might want to seek out a doctor who specializes in those areas, either in functional medicine or integrative care. Someone asked, they've been using low-dose naltrexone. Are there any long-term effects? there appear to be very few long-term side effects from this. I have not heard of long-term effects. High-dose naltrexone and naloxone can develop tolerance. And what that means is it stops working. This is less of a concern in low dose. Doesn't mean it doesn't happen. And I would urge you to put that question out into your chat box and into your to see if other patients have experienced this. And then finally, a patient with a spinal stimulator, can they also get DCG? Actually, I don't know the answer to that question. You need to ask the specialist who put in the spinal stimulator or an interventional pain specialist. Certainly things like diathermy is contraindicated with spinal cord stimulators, but I don't know about GRE. I will add, however, that you might consider asking your provider to use a CES device such as Alpha Stim. I use this quite a bit in my practice. This is much different than a spinal cord stimulator. What it does, it trains the brain to sort of re-respond or re-educate to some of the peripheral signals that come in and to respond differently than it has been doing. It's been FDA cleared, not approved, but cleared, different category for sleep, anxiety, and depression. However, I have also found it useful in pain. So those are some of the questions that came in. I'm happy to stop sharing now and open it up for further dialogue and discussion. And I hope this is helpful for you.
All righty. Thank you so much for all of that. Facebook, I think, had a little lag. So some comments came in, but I was unable to see them at first. So Jim, do you have any questions that you want to kick off with?
Well, Dr. Jonas, I thank you for a very high-powered lecture. I think what happens with a lot of people in our community, that care is so fragmented. And I was just talking to someone today who talked about in 7 minutes with his physician, not much could be done. So how do you change that mindset, especially now where there's so much stress on providers too?
Yeah, absolutely. Well, my best advice, it's very challenging. I mean, I don't have a solution for that because our system is fragmented. I often say integrate TED before integrative, right? Get a system that actually works in these areas. My suggestion actually is that you find a really good primary care doctor, because the role of a primary doctor is to provide this kind of integration, and a primary care team. Most of us with chronic pain, or many of us with chronic pain, they go see a pain specialist, but they're a specialist, okay? They do certain things. They don't necessarily integrate it. So a good primary care doctor. For those of you that are interested, there's a brand new report that just came out from the National Academy of Science, Engineering, and Medicine. It's called Implementing High Quality Primary Care. It's a brilliant report, and it talks about how to, in fact, find and deliver primary care that focuses on the team delivery and not on the provider, okay? Not just on the provider. And in fact, it is a team. And so finding a team that can deliver that in primary care and providing an integrator. In the VA, what we've recommended to them, there's a report that came out just before the pandemic by the Cover Commission that I sat on, and we recommended that the VA have a health partner or a health champion for every veteran. And that person would act as the integrator, a health navigator, a health coach in those areas, and a community health worker that could plug them into the community resources to get at these other determinants of health that you were talking about. So look for somebody that can do that. If you don't have somebody that can do that, find somebody. Sometimes it's a family member, but find a provider that has that kind of a team integrative approach, and use them as your primary integrator across systems.
Right. Dr. Jonas, just a concern of a lot of members of our community, also veterans, have been forcibly tapered from their opiates with long-standing care. And that's a major problem. And I know the VA is really looking to discontinue opiate therapy. How does someone who has benefited deal with that mindset?
Yeah. This is a huge, very, very good question and a huge issue, especially for many in your population, because the problems that I showed you with the chronic opioid use are real. People are getting addicted from it. On the other hand, an integrated pain management approach, and I have many patients like this, actually has to integrate, opioid use appropriately. And I have many patients that function perfectly fine on chronic opioid use, okay? And so to simply snatch that from them is not appropriate integrative care. I did a story with an NPR reporter a number of years. Alexis, if you're interested, Jen Dorr from my team can actually send that to you, that actually showed how a proper integration with ongoing opioid use and other kinds of integrated approaches can appropriately be used in a way to minimize them, not eliminate them, to reduce them and enhance the best quality of life and the best pain management in that area. I think that the same thing is happening, for example, in cancer pain, where people are trying to have their opioids yanked from them when they're some of the best treatment components for those kinds of populations. So it needs to be individualized and it needs to be integrated.
Yeah. Thank you for that. Alexis, any questions come in?
We are just getting questions, people asking about Dr. Jonas's website. So I'm just sending them there. But it doesn't seem like we have many questions outside the ones that were already submitted. Definitely people, of course, tuning in and learning more about how they can, educate their physicians a little bit more as well.
Yes, that's a good job. That's a good thing. I know that many CRP patients, if you're not proactive about this, then it's really important you become proactive about this, okay? Because this is your body, it's your pain, it's your quality of life. And the system, as I've shown you, and as the questions that Jim has just asked me, is that we're not always set up. The healthcare system is not always set up for your best interest. That doesn't mean the individuals in it don't have your best interest in mind. I mean, the health providers are very compassionate and are there to try to help reduce suffering, but they're operating within a system that actually makes it extremely difficult to do that in an integrated and coordinated fashion. And so work with them, become a partner with them, okay, in these areas, and find one that is open to these types of practices, to learn with you. And if you do that, then I think that's the best healing journey that you can have.
I thought you gave us some wonderful tools, and I really loved the slide with seeing the centers across the country now that are starting to build upon integrative care.
Yeah,
that's hopeful.
Absolutely, yeah. There is a academic consortium for integrative care. It involves 70 of the top medical schools around the country, which is over half of them right now. They all have integrative centers and activities in those areas, and many of them have focused on chronic pain. So I didn't put that on my website, but we can share that with your readers. It's imconsortium.org, and then you can find those centers around the country that go beyond even the network that I showed you.
That's great.
I do see a question that actually just popped up that I thought was pretty interesting. The person's asking, is RSD getting pushed back due to the pandemic? And I'm thinking they're maybe talking about, are people paying less attention to chronic illness and pain management because everyone is so focused on COVID? Is that something that you're saying?
You bet. It certainly has been. It's, I mean, the pandemic has captured all of our attentions. Nobody has escaped, the issues from it. And unfortunately, what happened at the beginning, since so little was known about this, and it was serious. There's no question about it. I mean, people were dying, and a lot of them, and it was spreading quite rapidly. But what happened is that so many people were afraid of coming in to actually get the routine care that they had. Some of the hoops they had to jump through, some of the news that they were hearing in those areas, they just actually, didn't want to come in. And so we saw them neglecting important areas, and those areas then got worse. One area is cancer care. We're expecting actually an epidemic of advanced cancer. We've already started to see it because people didn't come in to get screening so that they weren't catching early cancers. And now we're going to see it later. Normal vaccines for kids, okay? Those dropped off because people weren't coming in to get the regular vaccines in those areas. People with chronic pain weren't coming in. They were suffering from it. They were looking for workarounds. They were, getting things that they could get online, for example, because they didn't want to see this. And the data that's now coming out around the chronic pain epidemic indicates that it did get worse. It actually has gotten worse. There's higher numbers. There's more problems. The pain syndromes are getting worse in those areas. So, we should be out of the woods. Well, we're not completely out of the woods, but we're certainly getting out of the woods now. And so I encourage people to come in and really, as they come back in, to get good care, especially those in chronic pain. Come in and get the kind of services that you need, and make sure that they're the kind of services I've just described, that they're paying attention to you as a whole individual. Don't let go of that. Many of these primary care centers that had really good integrated systems, the ones I've suggested that you find and you look for, they actually were able to maintain good contact and good care services for that. Our foundation is a co-sponsor of a set of workshops that just were completed by the National Academy of Medicine, looking at exemplars that did well during the COVID epidemic in providing good whole person care, including for chronic pain in those areas. So go to their website. I think the study is called Health Financing for Health or something like that. And you can see the recordings on the website, and you can see examples of systems that actually did well during the pandemic and did not let it. They took care of people with COVID. They responded appropriately to it, but they didn't let it distract us away from the other important things that need to have care.
Awesome. I know it looks like we are getting a question that may be coming in. Not sure if this warrior is actively typing it and may have to send it to you after the presentation, but I'm also just checking the chat to make sure I didn't miss anything. I know there was one question, Tracy, that you asked about infusion, but definitely feel free to, clarify a little bit more. If we don't get that question answered here, we will, of course, follow up with you.
Okay.
Just double checking to see if I have the other question come through, but I'm not seeing it quite yet. Jim, do you have any other questions for?
I think it's been fabulous, and the array of resources you have provided us.
So many.
Will help people. Very durable. We're greatly appreciate that.
Well, good. I'm very happy to hear that, and they're all. I'm supported by a foundation, by the philanthropists Susan and Henry Samueli. All these resources are free. They pay me to just put them together and get them out there for people to use. So I hope people find them useful, and they get help, and they send them out to other people.
Okay. Yes. Not seeing the question come through quite yet, so I will definitely make sure that we follow up with you to make sure that we do get that person's question answered. But definitely thank you for this. For everyone who is watching this live, in case maybe you tuned in a little late, or you want to send this to someone else, this video will of course live on our Facebook timeline until our next Facebook Live, which is next Thursday. And we will also add this video to YouTube, so you of course can tune in and watch it there. And then if you have any questions for us, if you need a support group, if you're looking for a new physician, or if you want to tell your story in the RSDSA blog, please send us an email at info@rsds.org. I also included a link in the comments regarding joining our newsletter, joining us as a member, so you can just, of course, know what's going on here at RSDSA. And of course, send us a message if you have any suggestions for our new website, because I'm actively working on that. But all right, thank you so much, Dr. Jonas, and we will see you soon.
Okay, take care. Bye-bye.